Hello, and welcome to MedNews Week, the rising leader in global medical education. You're watching Medical Spotlight, where we highlight the inspiring stories and pioneering research innovation of medicine's rising stars and global leaders.
Hello, and welcome to Medical Spotlight. I am Helena Coloma.
And I am Gabriele Alves.
Today, we have with us Dr. Siddhartha Yadav from the Mayo Clinic. Dr. Yadav is an assistant professor of oncology and a senior associate consultant in the Women's Cancer Program at the Mayo Clinic in Rochester, Minnesota.
He specializes in management of breast and gynecology malignancies, hereditary and breast ovarian cancer, and malignancies associated with germline mutations in DNA damage repair genes. His research is primarily focused on identifying genes and variants involved in susceptibility to breast, ovarian, pancreatic, and prostate cancer using genetic, epidemiologic, and functional studies. In addition, he also focused on characterizing the molecular biology and clinical outcomes of tumors in carriers of germline mutations in DNA repair genes. Dr. Yadav has published more than 15 peer-reviewed articles in this area and has received numerous awards, including the Mayo Brothers Distinguished Fellowship Award and William A.J. Summer-Scale Award from Mayo Clinic, Young Investigator Award from American Society of Clinical Oncology, Outstanding Fellow Award from Minnesota Society of Clinical Oncology, Merit Award from Mayo. And also Associated Award from American Associated for Cancer Research. And he is also a passionate mentor, serving as a leader and educator.
Now, Dr. Yadav, behind every person in a white coat is a story and mission for why they pursued this journey and career. Can you tell us about yours?
Yeah, thanks for having me. So I think I go back to the time when I first went to med school. So I was born and raised in Nepal. And, when you're growing up in Nepal, you see a lot of different disparities within communities because healthcare is not easily available to everybody. So one of the reasons why I went into medicine was I was looking to do something that would be highly impactful for community in large. And along those lines, I was looking into different careers. And at one point, I met a priest or a Buddhist monk, and I started talking to him about what should I be doing with life. And he basically told me that you should do something that can sustain your career, but it still helps people as well. And then I asked him about what he was doing, and he said well, what I do helps people, but it may or may not sustain a career. And I was thinking about that, and I was like, okay, what is the closest thing that I can think of? And medicine kind of came closest to that. So that's kind of where I started thinking about medicine. And I went to med school, did my med school in Nepal, and then came to the US because I was doing my med school. I kind of became fascinated by this whole world of research, creating new data that can not only impact one patient in front of you, but can impact thousands of patients at the same time. To further pursue that passion, I came to the US, did my residency, and then eventually got into oncology. And now here I am today as a medical oncologist, but also I think of myself as a clinical translational researcher who is pursuing his passion. Of the reason why I came to the US was to pursue research. And I think of myself as more of a researcher rather than a clinician.
Given your background, and thank you so much for sharing, what makes a good mentor to you, and who was that for you in your journey in beginning medicine and thus far?
Yeah, that's a great question. Again, going back to my med school days, this was back in early 2000s when I was in med school, and this is in Nepal, so we didn't have a lot of internet. We didn't have access to what was happening outside of the world. So one of the things that I was personally very influenced by was my mentor at that time, who wasn't a mentor at that point in the beginning, but there was this professor in physiology. His name was Dr. Buddha Basnyat, and he's well known in Nepal. He walks into the door and he talks about and says basically, what you are reading in this book, and we had all these physiology books, is from 5 years ago. What's happening today in the world is not in the books, but in the journals, and you need to get outside of the books and think about broadly beyond books. And this was second year of med school, and I was very surprised to hear that, and nobody had really talked about that. We always thought like we're supposed to read the books and get everything that we know about from the books, and that's how we were going to be good doctors. So he was kind of a person who influenced me to think more beyond what was traditional learning at that time of textbooks, and start thinking about research, start thinking about a future career in research. And so he influenced me quite a bit in terms of thinking about future research, which is why, again, I came to the US during residency. And during residency, I was very fortunate to work with my mentor during residency was Dr. Dana Zaklik, and she's a very to the point kind of mentor and requires a lot from mentees, but was an amazing mentor in terms of showing me what was possible in the oncology world. And genetics was at that time just starting. When we think about genetic predisposition to cancer, it was just starting. And she was very kind enough to introduce me to the field, allowed me to do a lot of research, which eventually then led me to the oncology fellowship. And now I'm very fortunate to work with one of the world leaders in the field, Dr. Fergus Couch, who is my mentor right now. And obviously he's been an excellent mentor, and he's been helped me a lot through the recent publications and other things. So as I think of this journey, I don't think it would have been possible without the mentors that I have had, and the mentors who without any gains actually gave everything that they could to help my career. So I personally think mentorship is probably one of the key components of as we think about any research career, even in clinical career. I think that's probably one of the most important factors for success.
On top of having all these really inspiring role models in your life and mentors yourself, I know that you're a passionate mentor even yourself. Can you tell us more about this and what inspired this, and your initiatives as a mentor yourself?
Yeah, so I feel that, like I said, in my career, I wouldn't have been successful if there weren't people who, without any personal gain, gave back to me in terms of how they shaped my career. So I feel like it is our duty and a moral responsibility to give back to the community again. And this is where as I'm building my career, I feel that, there are a lot of residents, there are a lot of fellows and med students who come to me and who want to be in this field. And in that setting, I try to help them as much as possible. Obviously, as a mentor, it's not just about trying to give them research projects, but also to try to help them with their career goals, try to help them. A mentorship and mentee relationship, as you're aware, is very different than just saying, okay, you come over here and I'll give you a project and do that project, and come back again like 3 months later. It's much more than that, and it's a very special relationship. I feel it's almost like having a sibling in many ways, because now you are you cannot only have the good parts, but there are a lot of other things that you have to help them with, right? And that includes helping them with their personal life, includes helping them with their career, right? The choices that they are making in terms of making these decisions. So I've been very fortunate to have several mentees in the last few years who are in their residency right now. And one of the things that I have personally taken on is having mentees that are outside of my institution as well. So I do have mentees within my institution at Mayo Clinic. I have residents and fellows that are my mentees, but also outside of the institution. And the reason I did that was when I was a resident, one of the struggles that I initially had was finding good mentors within institutions, and sometimes in the area of your interest, right? So you may not have a good mentor in the area of your interest. And so if there are folks who are interested in genetic predisposition to cancer in this area, I have in the recent couple of in the last couple of years taken mentees from other institutions, mostly residents, to try to help them steer towards oncology fellowship and help them in whatever way I can with their career.
Thank you for that answer about the importance of mentee and mentor relationships. They're definitely guiding towards one's career and having someone there to support you. You mentioned having setbacks, and all humans deal with setbacks in their lives, but they can make you or they can break you. Would you mind reflecting on a challenging time in your life, and how you suggest one should approach these types of speed bumps?
Yeah, I mean, I think, like I think every career has ups and downs, and you know, we all have our expectations. I'll say that, right? And sometimes it's difficult, but that's personal expectation, and it's primarily personal expectation. Sometimes it's difficult to meet those. So I can give you a couple of examples where that happened in my career. One of the first area was when I was trying to come from med school into residency. As I had said, I primarily wanted to pursue a very much research focused academic career. Um, I went to a program which was very strong clinically, and I loved the program, and it made me who I am today. But it was a bit of a challenge in terms of trying to find research mentors. And like I said, I was very lucky to find my research mentor within all of those, but it was in the beginning, it was very challenging because, and this will happen to a lot of international medical graduates as they come for residency. It's often easier to match into programs that are much more clinically heavy rather than being academically or research heavy, right? So for me, it was a bit of a challenge during those residency years to find grants or do my own work. And like I said, I was very lucky to have a mentor who had those resources and who was willing to share those resources with me to allow me to do the projects that I did. So that was a bit of a challenging time. And the reason why I mentioned that as a challenging time is because at one point I did not see a career where I would say, to transition from going from a community-based clinical practice to going into a academic career. And that was a little bit frustrating for me because that wasn't why I had come to the US, and I wanted to be more in the research world. I wanted to do trials. I wanted to do all these, big research stuff that would change the world. And I wasn't seeing a career there. But I think what happened was, and rather than just doing the residency and my chief year, I in fact stayed over there for a couple more years because I wanted to build my CV so that I was competitive enough to apply for a fellowship and get into a program where there would be a strong academic focus. I think patience was the key, right? I mean, if you know what you want, I think sometimes you just have to be patient. And while that was frustrating, waiting for those many years, I think in the end, it was rewarding because, I was patient. I kept on doing the work that I wanted to do. I knew that I wanted to be an academic career, which meant keep on publishing. So I kept on doing that. And eventually I was able to, come to Mayo Clinic. And obviously the direction changed from there because now I have all the resources, all the things that I was looking for to begin an academic career. And now if I don't do things, then it's really up to me, right? I mean, I'm to be blamed if I am not successful in an academic career, then at least I can say that I tried. But I think that part in my life was a bit frustrating. But the advice that I would give to anybody who is going through the similar journey, and especially more true for international medical graduates, is to be patient. I mean, don't give up on your hope, aspirations, expectations. It will eventually come if you're persistent.
I love that. Persistence, is key. It's what drives us. And I want to ask you, looking back on your successful career thus far, could you tell us about one of your accomplishments that comes to mind when I ask that question? Or can you think of something that you would maybe change looking back in hindsight?
Yeah, I think if I had to change something, again, I think going back to some of those initial years, I don't think I would change anything. I would just say that I would tell myself not to be as stressed out about a lot of things because eventually things work out, right? And I think that's true. When you are in that whole mix of things, you don't know how things are going to go. I think all of us tend to get a lot more worried, get a lot more frustrated. And I think, we just have to remind sometimes that good things will come if we're persistent and patient, right? Thinking of an achievement that I'm very proud of, I would say that, the reason why I do research obviously is so that I can change, impact clinical care, right? And this is where, the reason why I like research, and don't get me wrong, I love seeing patients. I mean, that's my, it's like my, one day when I'm in the clinic is one of my best days, because then I get to talk to people. You hear so many stories. So I love that part, but I like research more because I feel like I impact 100 more, 1,000 more lives when I'm doing something that, changes the field. And along those lines, one of the things that I'm very proud of is, and goes into my fellowship, and last year of fellowship, we looked into this criteria for germline genetic testing among women with breast cancer, because there were a lot of controversies among women with breast cancer who needs germline genetic testing versus who does not. And so we came up with this, basically comparison of different guidelines. And out of those, what we came up with was to say, we think that all women under the age of 65 with breast cancer should undergo genetic testing. Now, fast forward to now, and all these years, all these guidelines hadn't really changed. But, and this is still sort of, it depends on when this podcast is released, but within the next couple of weeks to a month or so, there'll be a new guideline coming out, which will exactly say that, and it's based on our study saying that, all women under the age of 65 should undergo germline genetic testing. And to me, that's one of my proudest moments, because that's like doing the research, but actually seeing that it impacts, thousands, because that now when that guideline comes out, that will impact how women in the United States undergo germline genetic testing, and that's going to impact thousands of patients, right? And that's truly gives meaning to the research that I do, is to see that it goes from what I did in the lab, what I did in my, computer, to seeing that it can actually change practice. And I think I'm very proud of that, just because how influential it is in terms of changing patient care.
Dr. Yadav, thank you for this enlightening discussion about your background. And I personally think that talking about our failures is very, very important. And I love research as well. And it's very inspiring to me hearing from you about that. And now talking about those researches and innovations, we know that you are also involved in the treatment of breast and gynecologic cancers. Could you tell us more about that?
Yeah, so in my role as a clinician, as a medical oncologist, I primarily take care of women with breast or GYN malignancies, and primarily I see all kinds of different patients, but my practice, just because of my research, also has started focusing more into precision oncology, sort of genetics, just because patients come to me for those expertise, right? And you will see this as you start building expertise in a certain area, your patient population also starts reflecting that, just because patients seek you out. From a research standpoint, what I primarily started doing was more genetic epidemiology work. So things like, who needs testing, what are the outcomes? But very quickly, I've realized like the work had started moving more into tumor biology, and just by default, because, it's one thing when you look at differences in outcomes, the next logical question automatically becomes is, why are there differences in outcomes by the germline mutation status, right? What is it about the tumor? How does it influence tumor? And, it sort of makes a smoother transition into that area. So a lot of my work has now started moving more into the lab, into looking tumor biology. And obviously the next logical step from there is, if you're looking into differences in tumor, how can you leverage those changes to therapeutically target them? So now I'm also starting to move into a lot into clinical trials, because again, it's that whole transition that has started from working into outcomes-based research to going into tumor biology to now into trials. So I'm now also leading several trials at Mayo Clinic in breast and ovarian cancer, in terms of, and these are all precision oncology, more focused on germline mutation carriers. So that's kind of where my research portfolio lies. It's a very small but niche area, but it's also we say it affects, I would say, 5 to 10% of all breast cancer when you think about germline mutations, more so in ovarian compared to others in breast cancer. But it's a small area, but it's also for those 5 to 10% of patients who are affected by it, having a personalized treatment plan, I believe, is very important, because we can't just treat everybody the same, right? Because everybody is different. And if you have a germline mutation that led to the breast or ovarian cancer, we know that those tumors are different compared to your regular breast or ovarian cancer. And I'm very proud, and I feel privileged to be able to take care of this 5 to 10% of patients, because that feels like those are my group, right? And so that's my group of women that I'm very privileged to be able to take care of and be able to do research on and try to improve their outcomes.
Thank you for your answer. I love that. It's very fundamental. We treat the patients as in a unique way. And yeah, it was really, really interesting. We were all also studying about your last test paper that investigated the risk of contralateral breast cancer among women with germline pathogenic variants, you said now. And I'd like to know what motivated you to conduct this specifically study on contralateral breast cancer and the risk among carriers of germline pathogenic variants in ATM, BRCA1, BRCA2.
Yeah, so one of the things in the field that has been ongoing for the last couple of decades is that we did a lot of work in terms of understanding risk for BRCA1/2 carriers, right? Because these were the genes that were first discovered in terms of the breast cancer risk or ovarian cancer risk. What had happened is in the last 10, 20 years, we did a lot of work in terms of identifying what other genes are involved in predisposition to breast cancer. We identified ATM, CHEK2, PALB2 are as common ones. But what was not known was that if a woman, let's say a ATM, CHEK2, PALB2 carrier, develops breast cancer, are they still at increased risk of developing a second breast cancer or not, right? And a lot of places, what was happening was people were just extrapolating from BRCA1/2. We know that BRCA1/2, if they have first breast cancer, they are still at risk of developing second breast cancer and often will undergo bilateral mastectomies because of that. But that may not apply to ATM, CHEK2, or PALB2, but people didn't just have data. And you will hear from communities that a lot of women who were ATM, CHEK2, or PALB2s were undergoing bilateral mastectomies just because of that. And the lack of data, again, this goes to this whole concept of personalized medicine, right? If you don't have data, you can't really offer personalized medicine, because now you can't tell these women what is your risk. And so obviously they are left in a vacuum to make these decisions. So for us, that was not acceptable. And that's one of had been our key priority areas. We were just didn't have, and the reason why this research wasn't done was we didn't have a lot of good data set to answer these questions, because you need a large data set with long-term follow-ups to do this. What changed was my mentor, Fergus Couch, in fact, created this Carriers Consortium back in, he started this in, I think, 2014, 2015, before my time. And, within that consortium, we took large epidemiological studies within the United States and in fact did germline sequencing on those. So if you think about studies like Nurses Health Study, for instance, at Harvard, there's the NHS that has been going on. They started recruiting patients in the 1980s, 90s. They have blood samples, they have long-term clinical outcomes. A lot of those women in those studies eventually developed breast cancer and were still followed. So there were like several studies like that, more than 10 studies that were brought together within the US. They were all underwent sequencing. And then the first paper, we published that in New England Journal of Medicine in 2017, 2018. But then with all of those clarified, we now had a large database where we can look into contralateral breast cancer risk. And we took that opportunity and did that. And that's where, interesting results, I would say, we confirmed that BRCA1/2, even in a population-based, not in a high-risk setting, still had large, increased risk of contralateral breast cancer, which meant bilateral mastectomy was appropriate. But what we found was ATM carriers were not at an increased risk of contralateral breast cancer, which means that these women probably should not worry too much about risk of contralateral breast cancer and probably do not need bilateral mastectomy. Check twos were at almost twofold risk. Probably two was a little bit weird in terms of if the first breast cancer was ER negative, they were at an increased risk of contralateral breast cancer. If the first breast cancer was ER positive, they were not. But these results, I mean, I now use these results every day in the clinic, I would say. I recently, just last week, I had a ATM carrier who came to see me just because of this, because she saw this study and she was saying that she was thinking of getting bilateral mastectomy, but she saw these results and wanted to talk to me about these. And I said, like, based on these results, I don't see a reason why you need to get a bilateral mastectomy or not at any higher risk than any other woman out there, right? And so now it's reassuring, and that women can be reassured about their risk of developing second breast cancer based on the germline mutation status. And again, this is the best part of research, is you get to see that it directly impacts patient care, right?
Yes, thank you very much again for this answer. And it's very interesting to hear from you the implication in clinical practice and how this improved the patient care. And I think this is a very enlightening discussion. And are there any directions that you plan to pursue in your future research based on this results of this study? What are your plans for now?
Yeah, so there are a couple of things that we are doing. So right now I'm a ASCO Concurrent Cancer grant that in fact is based on this study, where what we will be looking at is, one thing we did was in that study was we said, okay, if you're a germline mutation carrier, what's your contralateral risk? But we also know that contralateral breast cancer risk is very different based on age, based on menopausal status, based on estrogen receptor status of the first tumor, whether you take anti-estrogen therapy or not. So, and some of these things we outlined that in the study published as well, but we need even larger numbers to actually tease those out and come up with a model where we can put all of those things in and say, if you're a 70-year-old BRCA1 carrier with breast cancer, do you need bilateral mastectomy, right? Questions like that. And the answer probably is no, because, even in that study, we showed that if you're over 65, your chance of developing a second breast cancer is quite low. So, but again, this goes into being more personalized rather than just saying, oh, you have a gene and you need bilateral mastectomy, rather than saying, well, you have a gene, but do you have a family history? What is your age at diagnosis of breast cancer? What is your menopausal status? What was that first breast cancer? How long are you planning to take your anti-estrogen therapy? Take all of that into account and be much more granular in terms of how we tailor our treatment options. So that's one direction where we are headed with this. And that's, again, like I said, is funded by a ASCO grant that I received earlier this year. The second direction where we are again going is looking into tumor biology, because therapeutics is always important. And so we will be at this year at San Antonio Breast Cancer Symposium. We have like 4 posters, 4 oral presentations, in fact, that will be talking about a lot about differences in tumor biology between germline mutation carriers and non-carriers. And what we are hoping to gain out of that, again, is by knowing the differences, now we can again tailor treatments that are much more appropriate for germline mutation carriers versus not, right? So again, going into this whole field of personalized medicine for germline mutation carriers, that's the area that I want to take on. And that's, again, funded by a couple of internal grants, but also we're looking for larger grants. But that's the direction that I'm taking for the next 2 to 3 years.
Yeah, this is a really complex field, and I think we should treat patients knowing about all this complexity and the variants, and remembering the patients are unique, as you said. And we appreciate the opportunity to learn about you and your work. We have one more question, the final question for you. When everything is said and done, what do you still hope to achieve in your career, and what do you want to be remembered for?
Well, that's an excellent question. And I wish I had a straightforward answer. I think, I think people talk about awards, people talk about grants, people talk about, what you achieve in your life. I think the biggest satisfaction in all of this, like I said earlier as well, is knowing that what the work that you did, in fact, changed outcomes for patients, right? And I think that's the most satisfying part of the job. that's true even in the clinic, and that's why a lot of us went into medicine, is because we love patient care, right? And when we take care of our patients and we know that we in some small way impacted their life by advising a particular treatment that may improve their outcomes, right? That's in the clinic. Same in the research world as well. I think the biggest satisfaction that I gain out of all of this is knowing that my work is going to change how patients are treated and hopefully will improve outcomes for them. I think what I want to be remembered at the end is by patients whose lives were impacted, and that's already true in medical oncology. If you talk to any medical oncologist, you will know that our patients typically love us, and they remember us, and we build such strong connections. And I think that's the most satisfying part of the work. And I think the same happens in my research work too, is that patients in the future, even ones that I have not seen or I haven't treated, are impacted by my research, and I think of that, like, because of this doctor did so and so research, that my outcomes were changed because of him. So I think that would be the biggest achievement of my life.
It was just such a pleasure learning about you and your important work. I just wanted to ask you, so how can our audience, especially since we have trainees in the audience, how can they connect with you?
Yeah, so they can email me, and I'm usually good about responding to emails. I'm also on Twitter, where my VMD, my email is my last name dot first name at mayo.edu. Like I said, I usually try to be available for a lot of people, even outside of the institutions. If there are specific questions, career advice, anything I can do to help, I'm more than happy to do so. And it's always, it's the same thing about giving back, right? I mean, a lot of people help me to get to where I am, and I would love to give back to other people who are in the same position as I was like 5 or 10 years ago.
Thank you so much, Dr. Yadav, for your inspirational story and sharing all your success, including all the challenges you encountered along the way. I'm sure our audience and even Gabrielle and myself were just truly inspired by your story.
Thank you so much for having me. I appreciate this opportunity to talk to you guys and your audience.
Thank you very much. It's a pleasure to have you here and to learn from you.
Thank you, Gabrielle. Thank you, guys.